Hello, welcome to another episode of Out of the Fire Podcast. Out of the Fire Podcast is the only podcast on the internet that consistently talks about fire and consistently has Ron Your Wongs on it, or at least for the second time, I believe, right?
I
No,
think it's the second
no,
time.
no, we had the hymns episode, so this is like the third.
It
This
is
is
the
like the
third.
third
Yeah.
because, yeah, so you're a frequent guest on this podcast, and yeah, I really appreciate that. So yeah, welcome Ron, and maybe give a brief intro and update what you've been up to.
Yeah, thanks, Gene. It's great to be back on. Ron Wong, one of the co-founders of De Facto Health. De Facto Health queries payers provider directory APIs and machine readable files, and we have a very large data set of healthcare providers and the insurances they accept. In terms of what we've been up to, some of the same things you've been up to. We've been sitting on some of these CMS national directory calls, seeing what's going on. There's just such a high volume of change going on, which is exciting, but also a little bit discombobulating at times, but mostly exciting.
Yeah, absolutely. And what do you think about all this stuff that's kind of been happening? And like, are you feeling like we're in a better spot? What is it now? Like, been a year since the whole CMS health tech ecosystem has been announced, and so there's a lot of work that's been done, and definitely seeing some progress, especially with the provider directory. Maybe like give your take, a couple points on what you think are the things we've done well, maybe, and things that we're still working on.
I think there's been a lot of progress. I think we're trending towards more transparency and more data availability, more data liquidity, which is always a good thing. I've been observing since 2021 that payers originally were slow to conform to some of API requirements around provider directory. It has just been picking up a lot, and that's because CMS has been paying more attention to it. They're releasing more requirements. They're expecting to use the data more for some of their own purposes, like the Medicare Plan Finder. And so I think payers are just more motivated to address these data requirements and fix some of the longstanding issues in their APIs. But I think you've seen this too. CMS is making some changes relative to the APIs. So there's still the requirement for these FHIR provider directory APIs, but there's also this idea that Medicare Advantage plans need to publish these ND-JSON files, so making provider directory data available in bulk so that CMS and others can just download it. CMS wants to use it for the Medicare Plan Finder, but others want to use it for their own data and analytics purposes as well. So, trending towards more data availability, and I think there's just going to be a whole lot of opportunity around that.
Yeah, absolutely. So I think that we've seen in April when the National Provider Directory dropped, and I jumped on it right on that. I was like, wow, this is so cool. Let me see what I can do with it. And had Claude Code like build a whole, basically system to evaluate and audit it and see, how good it is and what information, where is it good at, where is it not good at, what are other interesting points in. So if you go to ainpi.dev, you can see that. I've gotten some preliminary good feedback on that, and also trying to make it like a community resource, because the benefit of it is like CMS is now publishing this data, but
Right.
they're not necessarily providing you, it's like yours to do what you will with it, to say, right? And it's like if organization has resources, they may be able to do all kinds of stuff. But nowadays we all have these superpowers. So like, yeah, go to ainpi.dev and tell me how it's useful. But what are your thoughts on this initial stab at the National Provider Director, which obviously you had a great input on and probably was like one of the key people in making that happen. So maybe we could just touch on that.
I guess to clarify, I sit in a lot of these calls, but I'm by no means, involved or responsible for any of the national directory work. I'm like you. I take a look at the data and I provide commentary and constructive feedback, and as much as possible the regs, and I can spit them back out. But that's probably the extent of my involvement. But in terms of the national directory data release, I your information is probably a little bit more current. I took a look at some of the original releases where there was like an A version and a B version, and here are the differences between the A version and the B version. Honestly, I haven't actually taken a look at it besides through your platform since then. But it's very focused on provider endpoints, which CMS has been saying for the longest time that's going to be their first priority, is to aggregate, collect, release as many of the provider endpoint data sets as possible so that third parties and consumers and patients are able to connect to those endpoints to be able to retrieve their own information. I guess similarly, payers who are interested in connecting with those endpoints would be able to do that, although that's not, formally a part of that, the regulatory requirement. The channels are made available, and many providers are choosing to make those endpoints available to payers so that they can get data for, all of their, clinical data purposes. It's a good start. I think they're building on top of what, Lantern and NPES and some of these predecessor data sets are, trying to bring them together, trying to provide more searchability for endpoints on a per provider basis, per practitioner basis, and a per provider organization basis. But I think there's missing parts of it. There's a lot of providers without endpoints. I have opinions about how the logical model should be represented, and should these endpoints be associated with practitioners, or should they be associated with organizations, which are then associated with practitioners. But it's good that it's out there, and it's good that folks like you and others are providing constructive feedback, and CMS seems to be iterating on it and making improvements as they collect that feedback.
Yeah, and I think like the reason why they chose to focus on it is because they got a lot of feedback from the industry, specifically, a lot of digital health companies that have been working on their own, provider directory and NPI endpoints for a long time. And because that's the front door to letting the patient connect their data. And if you don't have a good provider directory and you can't find your provider and you can't find the endpoint, then it's really difficult, which is what has been basically the state. And that's why every academic medical center, hospital system, provider network, et cetera, that they have their own app, right? They have their own app because they want people to, here, just go to our app, find the providers that way, and then you can connect your data because we give you the portal right in there. But then there's like UPMC, there's like 5 different apps, and then there's like 3 different provider directors. There's if you have the health insurance plan, it's one. If you have the provider network, it's one. If you live in central Pennsylvania, it's another. If you use children's, there's another. It's like the soup, and this is just one provider system, right? So you multiply this out across the country, and we see how much this creates an overhead, probably in the billions of dollars, right? In terms of just surfacing provider data. So, question for you, Ron, is like, do you think should CMS run the director? So they've obviously made this National Provider Directory FHIR-based JSON files, right, available, but should they actually have a directory that people can go and, like, I think NPES, you can go and search, right, and do things like, should there just be like a website that has all of this information and then everybody just uses that as a source of truth? Or do you think that that's like a bridge too far right now?
I I think they intend to do that, specifically and maybe at first with Medicare Advantage. So they've made entirely clear relative to their Medicare Plan Finder rule that they want to ingest all the provider directory data from all of the MA carriers and put it within MA Plan Finder so that when Medicare beneficiaries are during open enrollment or shopping for plans, they can say, hey, my favorite cardiologist is Dr. Jean. Make sure you only give me MA plans with Dr. Jean in it. They started doing that a bit this past year, and I think they want to supercharge that starting in October. So at least for MA, they're going to be doing that. Whether that's going to be across the board and across all lines of business, I mean, they've signaled that they have a desire to do that, and certainly within previous write-ups and some of these RFI releases, they have described that concept, but at least they're going to start off with MA.
And is that, to your understanding, that's going to have all of the information? So like the endpoints and all the you know information that's associated with the provider in terms of all of their practice locations and organizations that they may be moonlighting on under or whatever? Or is it just like, here's Dr. Johnson, here's they're part of Johns Hopkins, and that's it, right? That's how it's been traditionally, I think.
It's going to start off with that. It's going to be,
Yeah,
Dr. Johnson. This is Dr. Johnson's address. Dr. Johnson works for UPMC or Inova or whomever. And
yeah.
these are the MA plans and the H codes related to the MA plans that Dr. Johnson accepts. Phone number, specialty. I'm not even. I don't even recall. I don't think it. hours of operation are in there. I think accepting new patients is in there. So it's the basic stuff. It's not currently endpoints, although I do recall there were some rules for payers to make endpoint data available on their providers, but it wasn't this particular rule. It was a previous rule.
Yeah. Yeah, and it's an interesting situation where the payer holds the kind of the relationship with the patient for providing the coverage
Hmm.
for the services that they're going to see the provider, but the endpoint is kind of like an interesting situation where it's like it's kind of important to both, right? It's important to the payer, it's important to the patient, and I think we just need to close that loop as we've been talking about this. I saw that there's a new pledge category on CMS health tech ecosystem for the prior auth,
Mm. Yeah.
and making that a part of kind of like one of the goals and have people kind of like connect the dots on that. Be specifically with 0057 coming to fruition in the first of the year, right?
Right.
So I think more and more these things are like showing everyone that it's all part of the same kind of loop of feedback mechanism that all connects to everybody, right? Like we've seen this disjointed, fragmented health system and health insurance plans be kind of like in their separate silos. And do you feel like this is a little bit like everybody coming together? Like I know I'm on those calls on the weekly National Provider Direct, and it's really encouraging to have like payers on those calls, right?
Yeah. I think there is a lot of, for better or for worse, and whether people realize it or not, there's a lot of coming together here. Even if it's just regulatory requirements and taking a look at them, you kind of have to have knowledge, not just on the thing that you're implementing, but also the adjacent things that are dependent on that thing that you're working on. You can't just implement compliance for a particular rule. Like all of these things are so interrelated. Directory is important for interoperability because you need to be able to, as you've described, resolve to the right endpoint, whether you're a patient or a payer or even a provider. Like a provider needs to resolve to the right payer endpoint for prior authorization. So all this information, enough metadata on providers and payers needs to be out there such that they can all interact with each other. So it's all connected, 100%.
Yeah. And I think it's important to see like the CMS's role in this. So like folks like Fred Trotter, huge props to him for putting all this together. It's really what like a federated graph looks like over a huge number of nodes in the system kind of. And it's not that CMS is trying to be like the master source from like, Bridget Tebow and bless her heart, master data management folks. Like CMS is not trying to do master data management with this. They're trying to do federated graph work where they're trying to connect the nodes of the system and have that connect together and maybe duplicate some of that like we've seen with the latest release of the endpoint data where they just squash that from like having all that duplicate data. But like what do you agree with that first of all? Or is just like is that what CMS trying to do?
I think there's a semantic conversation around this. Like we can splice hairs about what we want to call it. I think in a way, there's going to be some data mastering within CMS and within the National Directory because they're going to have to define some rules and criteria about what data is brought into the system and what CMS's opinion about that data is going to be. Just as an example, the Real Health Providers Act, which was signed into law in February, and it's got a sequence of requirements and steps between now and 2029. It's going to require that CMS has an opinion about what good directory data is and what the definition is and how to assess it because the law requires that MA plans publish or assess the accuracy of their data and publish the results of that. So CMS is going to have some type of opinion on it. Now, whether they're going to impose that opinion and say, hey, we're only going to bring this good data in and we're going to reject this bad data, that's an implementation detail that we're going to see. So I guess to your point, it remains to be seen what kind of data mastering controls they're going to implement on their national directory or whether it's just going to be a place where they aggregate data from a bunch of different authoritative sources. Whether they do it or not, I do think the industry wants to treat the national directory as a mastered system of record. I mean, that's what industry wants.
Right. Yeah. So, I mean, we see fire as kind of like a standard, right? So
Hmm.
we have the
What's the name?
National Directory of Healthcare Services Providers, I think it's called the IG, right? And that
Hmm.
IG work has continued on. There's like, I
Yeah.
think there's a version 2 of the, the that work, and we see that there's still gaps, right? There's still gaps on certain as you get closer to implementation. The initial step is like in the vis- visibility and monitoring of this data to see what level of data quality, what level of conformance it
Yeah.
has to the standards, which I think the MA plans are incentivized to do that now, right? Like they're saying, okay, well, you guys need to be internally monitoring how good your provider directory is, and how is it aligning to what the standard is, which is really the standard we have is the IG. You feel like that's clear enough for the payers to follow? And then what are some of those unresolved pain points or issues that we still see? We're seeing that, I think the one week there was a discussion on healthcare service, things like that, that are like not very well defined or like defined in a very specific way. Like, what are those still those issues that are not,
I think
you
they've
feel
been
like they're
doing
still,
a much better job than they have previously on defining what the success criteria are in terms of what data is available, what logical relationships need to be in place. That the document that serves as a technical guidance for Medicare Plan Finder goes into so much detail. Like so, and I think understandably so. Like the rules don't necessarily go into that level of detail. You have to accompany it with some type of technical guidance for the actual implementers to work on, and that can be iterated on a little bit more frequently than the rule itself. But I was happy to see that in it, and I was happy to see the level of specificity in there. And I think those payers and their vendors who are monitoring this and who are well versed in how to read an IG or a technical guide, some of those guys were able to respond to that. I was so surprised within like over a weekend. Like the updated technical guidance was dropped on a Friday, and then by Monday, I started to see some payers conforming to that. Like that
yeah,
2 years ago, that would have been unheard of. Like it's amazing. And I don't care if they're using AI to do it. That's fine. It's great.
yeah,
Like everybody should be doing that. Like drop your technical implementation guide that CMS released into Claude Code, interpret it and implement it. That's totally fine. Just do it,
right.
guys.
Yeah, and I think like I'm like the example of like here's one guy, right, with too much time on his hands on the weekend, and I imported every single publicly available provider data directory and made this resource all on my own free time with like not a ton of time that I sunk into that, right? So like it's just one guy. And yeah, I know like enterprise systems are a little bit more complicated. You have to worry about security and accuracy, but this is provider data. This is not really PHI as it's defined, right? I mean, it's important to be accurate and secure, but like to your point, like yeah, it should be whoever's like the architect or whoever's like the senior engineer on that team, just like do it. And it's like Claude Code can implement those specs in like an afternoon, right? So do you see that also now being a differentiator with payers and providers that are like out front, maybe adopting AI and rolling it out organizationally with teams that are a little bit more, not there yet, right? And having worked with a couple of different organizations over the last year or 2 years with rolling out AI capabilities, I can tell you from firsthand experience, it is going very slow. And there's a lot of, there's a lot of barriers to it, like even with organizational executive and even boards that want to push it and support it, there's just even things like Anthropic doesn't really even have like BAAs on all of their different tools right now that are available. So like there's a lot of like kind of interesting issues, but they're rapidly being I think, resolved. So yeah. So to your point, like if you're working on provider data, just like give everybody anything Claude Code and like start building these things like the way they should have been built from the start, right? Like we didn't have a lot of these, I guess, requirements before, like that it's bulk fire and JSON files, that it's
Yeah.
best practices on how you do the identifiers and like some of these other things. And by the way, guys, if you're working on one of these pair directories, I have a whole bunch of findings on AIMPI.dev that I would love to get people's thoughts on. But like even things like specialty taxonomy codes and how there's like several different ways to do that. if you take some of the different things that CMS even publishes, PCOS and NPPES and other things. So like we as an industry can help standardize that as well. Like we shouldn't just wait for CMS to like tell us what to do, essentially. I think CMS also doesn't want that because they want to get feedback from the industry. But I think it's like by having people suggest from their experience, that's how we get to a better state, right?
Yeah. Your original question was, is it a differentiator? I think it is right now because some folks are adopting it and some are not. I think very quickly though, it's going to be table stakes. You're going to be left behind unless you have it.
Hmm.
And we've seen that. CMS is more frequently coming out with new rulemaking and technical guidance and FAQs. And we're having weekly calls so that industry can provide constructive feedback to CMS. CMS acts on that very quickly and releases new guidance. And then you have to implement it. Like you can't be in the conversation and keep up with all the requirements to be able to respond to them unless you're using some type of accelerator like AI to be able to do that. It's not humanly possible unless you're using those types of tools. So it's a public service announcement for any payer organization or provider organization. Like you need, do it in a safe way, of course, but you need to provide the right tools to your team members to be able to keep up with this.
Yeah, the cycles have like compressed, right? So it's like
Yeah,
it's no longer, possible to say, "Oh yeah, we'll get this done in 6 months or 3 months or whatever."
no.
It's like you're choosing if that's your answer, kind of you're choosing to do that, not because there are not tools and processes available that are enable much quicker iteration cycle, right? So yeah, great point on that. Yeah, so what does good look like in like 5 years, Ron? What is your like, I guess, rainbows and
Unicorns.
unicorns?
Yeah.
Yeah.
We can dream. Let's dream. And I think this is all possible, right? I think every provider network is completely transparent and machine readable. The data out there is maybe not perfect, but is trending towards more perfect. We'll have a defined methodology for what good data looks like, and it's all patient centric. It's whether a patient can find a provider in a place and contact them and get the care that they need. I do think the bar is going to keep rising in terms of what information the CMS wants, what patients want, what providers are going to be willing to give, and what payers are going to be expected to publish. So it's not just going to be accurate addresses and contact information and specialties, but it will also be, as you and I talked, it's going to be the provider's endpoints. It's going to be URLs to book with them. It's going to be appointment slots. It's going to
Yeah,
be,
scheduling, you feel pretty strongly that scheduling is going to be part of that
yeah,
ultimately, because that's like one of when you're searching for a provider, what's the next step, right? What are you trying to do? Well, you're trying to schedule with them usually. So you feel like we have a good blueprint for that at this point, that maybe in the future we can see that part of that overall solution.
a few folks I know are working on this thing called smart scheduling links, which I think provides a really good blueprint for how providers can make appointment slots available. We're seeing interest on the provider side, lots of interest on the payer side to be able to use it. I'm joking, everybody. I'm involved with the smart scheduling links definition too, and I've been participating in some of the connectathons on it. Got folks at Be Well and ZocDoc and Optum who are also
Yeah.
helping out. So yeah, I think it's inevitable. I think there's a question about the timeline of it and what subsets of providers are going to be participating in it. But there are some like PCP, derm, behavioral. I think that's going to happen pretty quickly.
Yeah. And yeah, so Fire IQ also participated in that
That's
connectathon.
right.
And what was
Sorry.
that, January?
Yeah. Yeah.
January, right? But probably haven't been as involved lately. But yeah, looking forward to that CMS Connectathon in July, right? And you guys are going to be pretty sure having a work group on that. So like,
Yeah.
yeah, I'm always up for a new vibe coded challenge. So yeah, like I feel like the scheduling part, yeah, is both like voluntary adoption and then also like the regulatory need to do things that the industry has just like reluctantly or unreluctantly like just refused to do. Like we talk about EMR sharing their, you know, scheduling data and opening up their appointment and all that, and that being like a real pain point. And then there's, I think, also like some very valid criticism of folks like ZocDoc. I saw on LinkedIn that the way they charge providers for some of that is like not based on the appointments that are made, but like literally just
Mm.
being part of this. So like there's some innovation I think that's needed in terms of making this work for everybody, providers and payers and provider systems and obviously, CMS and everything they're trying to do with the ecosystem. But ultimately, do you think this will be adopted by folks like Epic? I think that's going to make or break it, right? Like if Epic is part of it, then we're off to the races.
Yeah, Epic was actually one of the first implementers of smart scheduling links back in the COVID era because I think the EHRs and the retail pharmacies and others and some of the big tech companies during COVID, during the vaccination period, or when the vaccine started to become available, they were just trying to aggregate vaccine appointment slots as quickly as possible. And so this was a lightweight solution that allowed that to happen. I'm sure they're going to want to implement things in a more scalable and robust production fashion, after that initial stint. But I think they're ready to engage on it. There's other EHRs who are interested. And I think from the provider side, I would encourage providers to think about this as a channel for, patient acquisition because payers want to use this data to clean up their directories. And, there are some payers who would love to be able to priority sort up providers within their directories that have available appointment slots and where smart scheduling links could be embedded within the directory results because then members get what they want. They want to be able to book an appointment lickety split. And, here's a link where you can do it. Here's the slot that you can do it. And like they've confirmed that this provider is available. So, I think this is a win-win on both sides if the providers are comfortable making those slots available.
Yeah, and I think like yeah, maybe figure out a way to pay for it that's friendly for
Yeah.
providers, and ultimately not just assuming that the system will figure it all out once this functionality is there, but also things like, if somebody books with you as a provider and you have to pay for it, even though the patient maybe didn't show or the patient is not, the new patient, whatever. There's all kinds of reasons why providers would lose money. So like we have to figure out a way that this is a valid business proposition for everybody. But I also think like once you open this up and enable this, it also solves so many problems with healthcare in general. One of which is like, you know, you can't find service. Like my example I wrote about on my Health Claw project, like the colonoscopy that took me a week to schedule. I mean, that's a very specific problem of referral scheduling, but that's like a standard of a service that you can probably get. Everybody, when they turns 45, they have to get a colonoscopy if you're in the United States, right? And obviously, that particular provider has zero. Yeah, they had zero business need for it to be a smooth, easy process because they have such a huge volume, I guess. So it's like things like automated scheduling solve that problem for them as well, and solve it for you as a patient. So it addresses everybody's needs,
Yeah.
right?
It's funny that, there's a bunch of dudes in their mid 40s at these connectathons and they always bring up colonoscopy as their use case, which makes sense. It
Because
is
like
something that you schedule.
that's everybody, but that's funny. But like that's one of the things that why they came out with those stupid fit kits, right? And they're
Yeah,
not
yeah.
stupid. Like I don't want to say that. Like anything to enable people to check your colon so that you don't have
Right, right.
colon
Yeah.
cancer, right? Like,
Yeah.
but that's why they because people can't make appointments, so they came up with these fit kits
Yeah.
so that you could do it at home, right? Like
Yeah.
but it's not the same as doing a full colonoscopy. Like they're not equivalent.
Yeah.
So like, but anyway, yeah, that is a funny thing that everybody uses that as an example.
Yeah. But to your original point about, I think the economics of it, I think we have to think about this thoughtfully. It's redundant, but there's the economics of it and there's unintended consequences and there's the risk of gaming on both sides, which I don't want to, I don't want to presume that everybody's going to try to game it, but there's always a risk of it, right? So on the economics of it, like who's actually getting value and who's paying for it? Like we need to be
Yeah.
thoughtful about that. Make sure that there's no unnecessary tolls, and there's the risk of that on either side. Both payer and provider side, because both getting some value out of it. But I also think this is a win-win. So there's got to be some reasonable way to make it happen. The risk of gaming it, there is a risk of gaming because with smart scheduling links, like you click through the link to be able to make an appointment, and then there's currently no, I guess, nothing that prevents a provider from implementing like 100 different questions to as criteria before you allow a patient to book. So at some point, there's going to need to be transparency on, okay, who's an eligible patient versus not for this appointment for this provider, because you don't want to bait and switch. You don't want to say, oh, here's this top-notch provider that everybody wants. Like, click here, there's an available appointment slot, and then the patient clicks through and oh, you're not eligible for this provider, but let me bring you over to this provider instead. Like, we want to have some transparency around that, which that's going to get more tricky around questionnaires and what criteria are you going to ask about those things. So we need to be thoughtful about all those things. And you're right, like, you can't just blow the gates open and do this. But I think we can do some reasonable small scale experiments to test it out and see what happens.
Yeah, I mean, it makes really, when you think of it from a value-based care perspective, I think, and from all these programs that I think that we see now, CMS really coming out with Access, obviously is a big one. That's like a 10-year program. You got
Yep.
LEAD, you got Maha Elevate, you got all these other things that are trying to move the needle on enabling value-based care that we've been working on across administrations,
Yeah.
across healthcare for 20, 30 years, whatever. And that's the ultimate goal of like quality measurement. Why are you doing quality measurement? Well, it's to enable, comparison of healthcare services across and to be able to select, or reward better outcomes, right? So the appointment itself is such a huge gate into that
Mm-hmm.
whole process, right? So if you think about it from an end-to-end perspective, probably like 50 to 75% of all the open gaps out there for a lot of these quality measures are because of the difficulty of patient being able to engage with the healthcare system and the friction around that, right? Specifically, the making an appointment with your PCP is like way harder than it should be, right?
Mm-hmm.
Finding an appointment to go do your annual physical, do all these tests, like me trying to close my own gap in care, and
Yeah.
then having to deal with this nonsense of 40-page intake form where I have to transcribe my whole medical history, which my healthclaw.io will be able to do. And I'm going to show that live at Dev Days, by the way. So check that
Nice.
out.
You're killing the clipboard. That's great.
Yeah, I'm killing the clipboard in my own way, right? Well, hopefully I'll be able to participate in the CMS kill the clipboard, but I'm killing it for me first, I guess,
Yeah.
with an agent. So like, yeah, so I think that that's the ultimate like unlock is once the appointment booking process and the scheduling process is as simple as it is to go on Uber Eats and order your lunch from your favorite pho or ramen place, whatever.
Yeah.
Like that's right. Would you agree that that's like the ultimate test of where we want to go?
For certain types of care, I think that's going to be the pushback on the provider side. Like, while we want to enable consumerism and choice where it makes sense, I mean, there's some things that you don't willy-nilly book an appointment for, but you need referrals. But yes, for
Yeah,
for
yeah.
many types of care, this is going to be possible. Yeah,
But it's like even once you get a referral, for system to be smart enough to know that yes,
100%.
you have a
Yeah,
referral,
yeah,
put the referral code. Like they do this currently. All of this exists. Like if you try to go and use any of these mental health providers, you have to have this EAP code.
mm,
You know this, right? Like your health insurance gives you like free visits that you can do with like Headspace or whatever.
right,
And
right.
they give you
Yeah,
an EAP code from your employer that you need to pass to so that it knows that this is a paid service that's been provided. Like all of these solutions already exist, like in practice for a lot of these things, right? It's just, it's so fragmented that it's like 10 different ways of doing the same thing, right?
right, right. Yeah, it's there. It's implemented in pockets. We just need to see more standard approaches for it, and it needs to be more universal.
Awesome. Okay, so well, are you building anything cool with AI? That was the last question I had, Ron, and see if yeah, like I'm holding this work group cohort of AI builders that basically is trying to get like some folks that have been in the space for a while and are doing stuff, but really like want to build stuff. And so I'm starting this cohort called Healthcare Build with Cloud Code Healthcare AI work group, and it's a workshop. So you can go to fireiq.com/workshop and sign up if you're interested. And so, Ron, you're welcome. sign
Oh,
up.
thank
But I
you.
think you've probably already like a little bit farther ahead than most people on some of that stuff too. And what are you trying to build in general, right? Are you like experimenting with stuff? Are you trying to build new stuff?
We are. I think our primary goal, though, is to automate what we're currently doing as much as possible. I mean, we're a weird company because we're small and we started before the AI revolution, but we've remained small even as it got started. So it might be a little bit easier for us to revisit current processes and automate them as much as possible. There's not going to be as much friction as those organizations that have built a lot of people infrastructure or things. So that's mostly what we're working on. It's just automating the data discovery, data pipeline processing, and data delivery. You know, to just harkening back to the previous discussion about payers adapting to more frequent guidance from CMS, we're seeing the same thing because as CMS makes or requires more data be made available, or they adjust the outputs that payers are obligated to conform with, and we can also adapt to that more quickly. So it's essential for us to be able to use these AI tools to be able to stay on top of that.
Awesome. Yeah, I'm looking forward to you publish a kind of state of the provider directory, state of the payer directory, and I'm sure you're like working on that. Is there one coming out soon, or am I like, did I get my timings wrong a little bit?
Well, it's going to be a little bit weird this time because of the change in output format. So it's not going to be the APIs anymore. Well, the APIs are going to continue to exist, but then there's also going to be the MA files, the big NDJSONs.
Yeah.
So I think more folks are going to be interested in that. So we may do some analysis and assessment and publishing on that. We do have a piece coming out. There's a June. So I've just authored something that will help people think through all the different accuracy assessment methodologies and arrive at that meeting a little bit more informed and ready to talk about the different options.
Awesome. Yeah, interesting to see all the cool stuff that de facto kind of leads the industry on in all this stuff. I know you've been a resource for years for people that, really just like starting from scratch, like nobody had any idea about any of this stuff. And yeah, so I think as we get into these July, I think there's a July date for the CMS Health Tech ecosystem, and there's a lot of activity around that.
Yeah,
If people are interested in getting involved, you can be a friend of the ecosystem, as they
friend.
say, which is like what I am right now. And
Yeah,
then also you can be like a patient provider caregiver if you're a caregiver, which I'm also. But like if you want to represent your company, you can pledge on behalf of your company and be on the calls with myself and Ron and Fred and all the other payers and providers that are every week, which is really cool. It's almost like a little, health tech nerds, but for CMS. Like they have a Slack. It's almost like a health tech nerds, but for CMS and for all this other stuff that's happening in the industry, right? Which is really cool. We've never had that before.
yeah, it's really cool, and it just tightens the feedback loop between rulemaking and guidance and testing it out and constructive feedback and just refining it. So I think the industry could just move a lot faster, but you have to be engaged. You have to be involved.
Yeah. Yeah. All right. Cool. Well, thank you very much, Ron.
Yeah.
Again, I'll love to catch up with you. There's so much activity going on that it's like there's always a lot of stuff to talk about. And you make it so easy to understand and engaging that, kudos to you. It's like kind of a boring topic for some people with the provider data, but not for provider data nerds like us, right? And maybe sometime we'll convince Bridget to come along with us and maybe even Fred. I don't know
Yeah.
if the CMS will let him do that, but yeah. So, all right, cool.
Thanks for having me.
Check out. Yep. Thank you.